All right, so my talk today is going to be on vertigo and what we do in the ER for it. So, goal of this talk, I want to make sure that we know what vertigo is, how to characterize it, how to diagnose it, different physical exam maneuvers, and then treatments. So the reason I picked this topic is because vertigo and dizziness are one of the most common ER complaints, and yet I feel like a lot of times what we do is we see the patient, we try meclizine, it works, and we send them home, which isn't always, there's no data to prove that meclizine can diagnose like a benign positional vertigo. So I feel like a lot of the more intricacies of diagnosing it kind of get lost. So what is vertigo? It's the perception of movement, rotational or otherwise, when no movement exists. Now the problem with a lot of our dizziness vertigo complaints is the complaint itself is pretty vague. People will say, oh, I just feel dizzy, or I just feel lightheaded, or you'll have an Arabic speaking patient with a translator phone trying to explain like the sensation that they're having, and there's no clear-cut method that they really can do it. So history is important, obviously, but a lot of times the things that we think are particular to one cause or the other don't necessarily fit. Symptoms, again, dizziness, room spinning sensation, nausea and vomiting go along with this, and unsteadiness, a lot of gait abnormalities. So in terms of characterizing different types of vertigo, so there's central and peripheral. Central is what we worry about the most, so these are strokes, hemorrhages, tumors, MS, Parkinson's. Peripheral is what we kind of see a lot more often, I feel. These are problems with the vestibular system. So BPPV, labyrinthitis, Meniere's, those are the most common things that we see that cause peripheral vertigo. So just some pearls really quickly about peripheral vertigo in terms of differences in the history that you'll see. So BPPV, which is, I feel like, what we see very often. These are loose calcium carbonate stones. They're usually brief periods of vertigo that last for less than a minute or so. Meniere's disease, nobody really knows what causes it. There's some brief theories. But basically this causes recurrent spontaneous attacks in combination with tinnitus or a feeling of fullness in the ear or hearing loss. And then labyrinthitis, this is inflammation of the labyrinth caused by a viral infection. So you'll see this in somebody who recently has a URI or has a URI, and they're having this new vertigo sensation. Now, symptomology, again, it's pretty subtle because a lot of the symptoms are very difficult to describe, especially for somebody who doesn't have a medical background. So history is important mostly for risk stratification. Your patient has had 3 strokes in the past who comes in with this new vertigo symptom. You're going to be a lot more concerned than a young patient who's had vertigo in the past who comes in with the exact same symptoms. Hearing loss, though, usually does not occur in central vertigo. So physical exams. So don't forget all your other causes of dizziness, cardiac, infectious. Make sure you do a full physical exam. An ear exam is actually pretty important. If you see signs of infection, that kind of risk stratifies somebody. We don't usually do this a lot of times. Most of our otoscopes are broken, or just it's hard to find one. But it is important to do a full ear exam. And then neuro exam, obviously do a full neuro exam. But you want to focus on the extraocular movement, cerebellar testing, and gait. Nystagmus itself, so there's different ways to describe nystagmus. It's either gaze-induced, spontaneous, positional. With central vertigo, you'll usually see that first line is wrong. Central vertigo, you're more likely than peripheral to be rotatory or vertical. So rotatory nystagmus and vertical nystagmus, and I'll go into this a little bit more, usually is a lot more concerning. What we generally see with peripheral vertigo is a horizontal, unidirectional, gaze-induced nystagmus. Now the HINTS exam. So the HINTS exam became really popular a couple of years ago. And what they say is that it's 100% sensitive for central cause of vertigo. So it's a little confusing. A lot of people don't really know what it means, what's a positive test, what's a negative test. So a HINTS exam, it's 3 different tests. It's the head impulse test, you're looking at nystagmus, and you're doing a test for skew. The head impulse test is the one that kind of confuses people a little bit. An abnormal finding on a head impulse test is actually reassuring. So if you think about what you'll see in what is a head impulse test, you're basically holding somebody's head, asking them to look at your nose, and then turning their head very quickly one side to the other. And you want them to focus on your nose, and you're looking for different movements in their eyes. So if you do this to somebody who has no symptoms, they'll be able to track your nose without any issue. There should be a smooth movement of the eye. Somebody with peripheral vertigo, when you do this, you'll see these saccadic movements. So while you're moving their head, you'll have these saccadic movements while they're trying to focus on your nose. That's an abnormal test, but it's reassuring because it indicates peripheral vertigo. If somebody's having vertigo and it's a central lesion, they won't really have these saccadic movements. They'll have a normal test. So the interpretation of the head impulse test, at least, can be a little bit confusing, but important to know. Nystagmus, central vertigo, again, is more likely to be rotatory or vertical, and peripheral is more likely to be unidirectional and horizontal. And then lastly, the test for skew. So you have the patient focus on an object, either your nose or something far away, and you cover one eye and you uncover it quickly, and you'll see the other eye deviate, meaning that they're using their extraocular movements basically shift whether you cover one eye or the other. Now, when they say the Hintz exam is 100% sensitive for a central lesion, anything that's abnormal in any three of these tests, you have to do a little bit more of a further workup for a central cause of vertigo. Now, maneuvers. So we all know what these maneuvers are, but how many of you actually do them in the ER? It's especially if you're at Moses and your patient's 3 stretchers back, it's hard to get enough room to do these tests accurately. But the Dix-Hallpike, basically, this is a test to diagnose benign positional paroxysmal vertigo. And the way you do it is, it can be a little difficult. You need some room, you need to position the patient correctly, sometimes you need help. If you ever work with Buzz at Moses, he does these tests a lot, more than anybody else that I know. But basically the test, you're sitting up, your head is pointed at a 45-degree angle, not your head, your patient's head, you're gonna point at a 45-degree angle. And then you basically lay them down supine very quickly and have their head flex 20 degrees off the end of the bed, right? So again, you need a little bit of room to do this, and sometimes you do need help with somebody else. Some patients they're just too symptomatic to do this. You move their head even a little bit and they just feel really nauseous, they're gonna throw up. Obviously don't do it then. As you change position, so from sitting up to supine, you watch for 45 seconds. You watch their eyes for 45 seconds for nystagmus. Now, central vertigo, peripheral vertigo, you'll sometimes see 15 to 20 seconds of latency. So you won't see any nystagmus. You actually have to watch their eyes for a pretty long amount of time. And then going on to the Epley maneuver, so this is similar to the Dix-Hallpike, but the beginning is the same. You sit them up, you lay them down really fast, head is flexed off the bed, and then you hold their head in a certain direction, the way they're facing, for 1 to 2 minutes. So this is actually pretty difficult to do, especially if your patients are very symptomatic, because not only do you have to hold their head in one direction for 2 minutes and then move it the other 45 degrees for 2 minutes, you actually have to get them to turn over on the bed without really moving their head in order to complete this. And you have to repeat this 2 or 3 times. This can take 10 to 15 minutes, and when you're stuck in a busy ER, sometimes it can be difficult. Dix-Hallpike is for diagnosing a benign peripheral vertigo. The Epley maneuver is for actually treating it. It helps move the otolith out. Aftercare, we don't really think about this too much, but apparently a lot of people actually advocate for putting the patient in a soft collar. I don't know if that's really necessary, but tell them not to move their head too much, and they're actually technically supposed to sleep at a 45-degree angle for the next 2 nights. Again, not a lot of people are going to be able to do this. In terms of treatments, so this is kind of what we end up, especially in our younger patients who we're not really worried about a stroke. We see them, we just give them meclizine and we check back in half an hour. But meclizine is, one of the first-line treatment. It's very good. Benadryl also. These are both antihistamines and they both work well. Occasionally, if that doesn't work, Valium I've seen used and works pretty well also. And if somebody is, very symptomatic even after these treatments, then you do need to think, am I missing something more central here? Make sure you refer them back to the primary care doctor. A lot of them will need vestibular rehab. And Meniere's disease should actually be referred to ENT. Again, anybody with vertigo and tinnitus or a feeling of sensation, you should think about this. They may need further workup and more symptomatic control. And that's it. Any questions?
What is, when you said Dix-Hallpike is used to diagnose BPPV, is just getting symptoms from it diagnostic, or is it?
No, symptoms, or you see nystagmus as you're holding their head for that 45 seconds.
I don't actually think those are either diagnostic. I think it's that you extinguish it after doing it multiple times. I think that's the only thing about it that can be diagnostic. The other two may suggest it, but Central can have that as well. time you do it, they get less and less symptomatic. That,
Yeah, that's true.
I think is the only.
There's a fatigability that you can see with that.
And then I think with what makes the hints very, one, don't do hints as your end all be all yet. Just for the love of God, don't. But two, and if you want to prove why, go on YouTube, watch videos of different hints exams being done, and then see if you agree with, or can even tell what they're judging as nystagmus or head tilt, whatever. But if you're going to do it, and the head impulse is that double negative test, right? Double negative wording.
Yeah.
So if they can stay focused on you when you're doing it, they're either, and they're symptomatic, right? This is not for someone who's
It's only when they're symptomatic,
and
yeah.
they focus on you, right? They're either totally normal and not symptomatic and lying, or they're having a stroke. So you don't want them to be able to look at you. If they look good, it's bad. It's a weird. So
Yeah,
Moses
it's confusing.
just had the QI case, I don't know, 2 or 3 months ago, where they discharged, saying in the chart, hints reassuring, didn't really detail what parts of the hints or what it meant.
Who did it?
And lo and behold, they come back herniating from their cerebellar.
What was it done by DDR or was it done by John?
It was done by us.
Yeah, because I really feel.
It was done by a competent resident who's attending, then wrote hints by hints by resident or hints okay. And they were reassured by our by the confidence of our residents, and then that blew up.
I'd be very wary of the resident doing it or myself doing it.
Yeah,
I
this is not prime time.
Yeah, and any test which is either 100% sensitive or specific, you should be a little bit suspicious about, I feel. The Haque exam, you need experience to do it, and the thing about Vertigo itself is it's all a gestalt. There's no clinical decision rule that you can use. You have to take into account risk factors, previous history, how they look, how they feel in their neuro exam. All of this, there's no hard and fast rule for it, which sucks for us, but it's important to know the different aspects that you can use to either say, like, this might be this or this might be that.
What would you say about this statement, which I've been told, I don't know if it's true or not. A person who has peripheral vertigo may not want to walk, but can. A person who has central can. Or if they do, it's going to be like it's going to be a cerebellar gait type thing where they're off. They're walking at the wall.
Yeah.
Kind of.
It sounds good, but all I can say, I think it's just a really clear.
I think it's different.
Too.
So this is why that case, and this is why at Monty you now have that MRI stroke rule out.
Yeah.
Not that. I'm sorry. There's a new order for MRI that just is just stroke protocol. It's a very fast MRI. It's not as detailed as like going through the MRA full thing when neuro comes down and tells you to order those 3 tests. But it is for this case. It is for the vertigo that you just want to quickly get a rapid MR. It takes like 15 minutes.
Yeah, I mean, Vertigo is one of those things we should be careful about. I feel like a lot of us brush it off when people start feeling a little bit better, but you gotta make sure a cerebellar stroke is something that's pretty life-changing, so you gotta be very careful with it.
With the test of skew, it seems like if you actually were able to photograph it, and they would do it in slow motion, you might get a better, feeling.
That's what some people said. Use your iPhone with the slow-mo camera.
Right.
Oh, that's not a bad idea.
And when
Yeah.
you see people who did these studies, the guy is a neuro-ophthalmologist.
Right. Again, 100% specific. I don't know exactly who was doing that test, but you should be a little bit suspicious when anything is 100%.
Yeah, and it was done by someone with a specialty in that area.
Right, like a fellowship in the HIMSS exam or something.
But I
like
do
that.
think, photographing it would be, very helpful.
Right.